allow you to. Perfect.
Yes, sir.
So later we'll sharing the assignment via Irfan. I will let Irfan know everything. So before that, can I know roll number 16 is here and 41? Roll number 16 and 41. Roll number 16, 16, 16, and roll number 41, 41. Okay. Okay. So it's okay. Let them. Junaid, send in a chat roll number 16 and 41 in this chat that when they come in, let us know they are here. Okay.
Okay,
Let's
sir.
start. Okay. Let's start with the
Sir,
dental caries. Yes.
sir, but when they will get into the class, then
You
they will
cannot see the chat.
yes, sir.
Okay, and at the end of the, okay, no need to send. And at the end of the class, I will again ask. Okay, no problem. Don't worry. This is not a big problem. Not for me, at least. Dental caries. I hope everyone can see the slide. So, dental caries. Let's start with the parts of the tooth again. Of a tooth, there was anatomic crown, there was anatomic root, and pulp chamber. So now, after we have covered the dental anatomy, the introduction, the oral cavity, anatomy of oral cavity, palate and tongue, and how to take history or case presentation of diseases. Now we are going towards the pathological part or disease part of the oral cavity, and it's the why not dental caries? The most one of the most common disease in the world, dental caries or dental decay or dental cavity formation, which I hope have not experienced, but we have, maybe all of us have experienced at least once in our life. So before going into the cavities, let's revise the parts of a tooth. So we have anatomic crown, which is a portion of the tooth covered by enamel and dentin. It projects above the jawline. This is the crown, anatomic crown. And then we have anatomic root of a tooth. Is the lower two-thirds of the tooth, held in the place by cementum toward, and its apex is towards the alveolar bone, inside the alveolar bone. And pulp chamber houses the dental pulp, an organ of myelinated and unmyelinated nerves, arteries, veins, lymph channels, connective tissue cells, and various other cells. You're talking about the pulp chamber. So dental caries or dental decay, a cavity or caries is a hole in the tooth that is caused by decay. Caries is a hole in a tooth caused by decay. Tooth decay, also known as cavities or caries, is the breakdown of teeth due to acids produced by bacteria. The cavities may be a number of different colors from yellow to black. So the cavities may be stained with different colors, including yellow to black and then can be brown. Symptoms may include pain and difficulty with eating. Decay occurs when plaque, which is the sticky substance that forms on the teeth. You already know the difference between plaque and calculus. So decay occurs when plaque, which is the sticky substance that forms on teeth, combines with sugar or starch or both of them of the food we eat. As you know, our saliva contains salivary amylase and salivary lipase, and the amylase helps to break down carbs or the starch in the mouth, and that sugars or simple carbs, carbohydrates, and starch will make plaque with the help of bacteria, because bacteria love carbs, sugars, simple sugars, and produce acids. The acids will create breakdown of teeth, enamel, dentin, and cause caries and tooth decay. This combination produces acids that attack the tooth enamel, because outer side we still hope there is enamel. And then after the enamel caries, we go down deep down to the dentin caries. Dental caries remain one of the most, it's not dentin, it's dental. So for the tooth caries, Dental caries remain one of the most common diseases throughout the world. That's why it's important to study first about the dental caries as a medical student. Eating healthy foods and avoiding snacks and drinks that are high in sugar are way to prevent decay. Hmm. Okay, next we go for the causes. What are the causes of dental decay? The interaction between four main factors is required for caries formation. There should be a tooth surface or enamel or dentin. There should be caries causing bacteria. Streptococcus mutans. Streptococcus mutans is one of the favorite of the examiners to ask. And then there is lactobacillus. Fermentable carbohydrates such as sucrose and thyme. So we need four, there are four etiologies and progression of etiology which cause the pathology, that there should be a tooth surface, then there should be presence of caries causing bacteria such as Streptococcus mutans, then there should be fermentable carbohydrates such as sucrose, and time is required. If these three are present, then just time is required. If you don't take care of your tooth, don't floss, eating habits are poor, we have mouth issues, we have oral cavity issues, no poor oral hygiene, then just time is required that there will be some dental cavities or dental caries or tooth decay. So here on the right side, we have some causes of dental cavities. Poor oral hygiene. This includes irregular brushing, not flossing. Yes, brushing and flossing are different things regularly. Not cleaning your tongue and not using mouthwash. So we have permanent set of teeth only once in a life. Please take care of them. Deep tooth crevices. Individuals who have deep crevices in their teeth are more susceptible to tooth decay. So they have deep grooves here, they are more susceptible to tooth decay. And some of us have gums, which huge gums which cover the teeth. We don't have crevices and interdental crevices and interdental crevices. So those are relatively protected. But if you have these four factors, you just need time that your teeth will be done for good. And then we have eating habits, bad eating habits, for example, processed food like bakery, high in sugar and carbs, carbohydrates is leading cause of tooth decay. Then we have drinks like sugary drinks such as juice and soda are also damaging to your teeth because their pH is acidic, low. Dry mouth issues, saliva helps inhibit the growth of plaque. But if we have dry mouth, we are not taking hydration, our hydration is not proper, dehydrated, then there will be less saliva production, and then there will be no protection and plaque will grow. And tooth grinding, tooth to tooth grinding leads to tooth decay because it wears tears, physical damage as it wears the outer layer of tooth enamel. Anyone of you can tell me what is tooth to tooth physical wear damage? The medical term for tooth to tooth wear damage is
Attrition.
perfect, attrition. So now we go to the next slide. These are the stages of caries development. We have a healthy tooth here with everything intact. Enamel is intact, dentin is beautiful, pulp chamber looks cute, gingiva, gum, gingiva, everything nice, root canal intact, cementum is there, periodontal ligament should be there, and bone, alveolar bone, nerves, blood, everything intact, crown, neck, root looks amazing. But now caries start. If the enamel is involved, these are known as enamel caries. If deep dentin are involved, then enamel is already gone, that part, so it is dentin caries, and these are the deep caries. And then if pulp is involved, we have arteries there should be inflammation because there are arteries, there are immune driving cells, because pulp has arteries, blood supply, blood has cells, white blood cells, some of them they help in immune system, and immune system, so inflammatory they also have inflammatory response. That's why pulpitis. That's why it's not caries, because it has disease, which includes decay and infected pulp, really leading to abscess formation. Okay, another stage of caries, we have caries, enamel caries, and then dentin caries, infected pulp, pulpitis, and periodontitis. Okay, so these are the 4 stages, and these 2 stages are not painful because nerves are not reached. But once pulp is involved, we have nerves intact there. So pulpitis is painful, and this periodontitis with abscess is very painful. I hope no one reaches here. So we need to take care of our teeth. So dental caries types. Number one, we have enamel caries, and the second is dentin caries. We have different types of caries too: deep caries, superficial caries, or interdental and intradental, and a lot of types, and pit fissure type, and this and that. But I think for our medical students, these 2 types are important to know. No need to go for the histopathology and deep to the types of dental caries or shapes of the dental caries. So here, enamel caries and dentin caries, we go for the enamel caries. The initial lesion is visible as a white spot. So enamel caries initially starts as a white spot. Okay. This appearance is due to demineralization of subsurface layer. So white spot, initially there's a white spot because of the demineralization, with the surface enamel remaining more mineralized. So surface enamel is more mineralized, but the deep is subsurface layer, excuse me, and that there's a white spot there, which means something is going on. Looks like this relatively. This looks like, if your brightness is good, I think so, but it should be relatively whiter. So white spot is there because of the demineralization of subsurface layer. And then with continued acid attack, the surface changes from being smooth to rough and may become stained. Stained means there will be coloration, which can be yellow to black or brown, anything. As the lesion progresses, pitting, and eventually cavitation will form, right? There will be multiple pits and cavitation will form like this. This is dental cavity. You can see cavity, and this is interdental cavity or interdental pit fissure. Is you no need to know that. So this is important how enamel caries are formed. These are the 2 types of caries. Enamel caries, this is the pathophysiology. And dentin caries, of course, when enamel caries reach to the below, then demineralization of the teeth follows towards the root or apex, and bacterial invasion will cause dentin caries when it goes deep. So this is dentin caries, and this is enamel caries because dentins are not reached, and then almost here it is pulpitis, almost. Yeah. Okay, perfect. Now, clinical features of dental caries is usually asymptomatic because we have just studied which ones? Enamel and dentin caries, and nerves are not involved. So usually asymptomatic because pain is not there unless pulp is involved. And then pulp is involved is pulpitis, but we are just studying caries. So usually asymptomatic, no pain. That's how you remember. The earliest sign of the caries is appearance of chalky white spot. You remember white spot? And on the surface of tooth indicating an area of demineralization of enamel. Again, repeated. As the lesion continues to demineralize, it can turn into yellow or brown and turn into cavity or cavitation. Before the cavity forms, the process is reversible. But once the cavity forms, the lost tooth structure cannot be regenerated. So once the cavitation is formed, then it is irreversible. But before the cavity, it is reversible. We can form some amalgam or some give some how to say filling. Layman term is filling. Yeah. And then symptoms of right side, symptoms of dental caries. We have small holes, pits in the affected tooth, and then consistent toothache in case of deep dental caries. Okay. Next, Brown and shiny lesions suggest dental caries were once present. So if you see brown or shiny lesion, it means they are old caries. But if you see yellow, it means just stained yellow, means the cavities were formed and they are just they are still active. They are in still active form. Brown and shiny lesions suggest dental caries were once present, but the demineralization process has stopped, leaving a stain. A brown spot that is dull in appearance is probably a sign of active caries. Okay, so brown spot that is dull is probably a sign of active caries. And brown and shiny. So now we can see two things here. A brown spot that is dull is active caries, and brown and shiny lesions means the caries were once present. Okay, perfect. Thank you. Good to remember. Once the decay passes through enamel, so the outermost layer enamel is breached. The enamel is breached. Now the dentine, which has passage to the nerve in the pulp cavity of the tooth, becomes exposed and causes toothache. So until the pulp cavity is not reached or the lower deepest layer of dentine is not reached, because you remember dentinal tubules had dentinal fluid. Dentinal fluid has some cells or dentoblasts, and they also had some nerve endings in the from the pulp in the dentinal fluid in the dentinal tubule. So dentinal deepest layer can be a cause of toothache. As you remember from the previous slides, the pain may worsen with exposure to heat, cold sensitivity, or sweet foods and drinks. Dental caries can also cause halitosis or foul smell, foul taste, bad breath. Complications such as cavernous sinus thrombosis, CST, and Ludwig's angina can be life-threatening. So let's see what are those. Cavernous sinus thrombosis. Okay, chat. Well, number 41 is here. Roll number 16, roll number 41. Oh, Rafiullah.
Yes, sir, I'm here in another office.
Okay, okay. Roll number 16 is still not here. Okay. This guy. So, cavernous sinus thrombosis, as you already know from your medicine subject or lectures. Facts. Most cases secondary to infection. So we have caries, dental caries, and this is also kind of infection or pulpitis or abscess. And then because the veins are connected, so most cases secondary to infection located in the medical aspect of the face around the eyes and nose. Yeah, a blood clot in your cavernous sinus. So cavernous sinus thrombosis is a blood clot in your cavernous sinus. History and presenting, physical examination. Headache, there could be headache, there can be low-grade fever, bilateral periorbital edema because cavernous sinus is a root, and then the veins cannot drain the blood back. There will be edema because of the stasis of blood, double vision, cranial palsy, because around the cavernous sinus there's a lot of nerves, trochlear, ophthalmic. So ophthalmic is here, and then it can cause double vision, confusion, seizures. These are when cavernous sinus thrombosis is there. These is the history. These are the complaints. On physical examination, you can find these. And diagnosis is by MRI or CT of orbits with contrast. So MRI or CT. So here you can see thrombosed cavernous sinus, CST. And treatment is broad spectrum antibiotics. Yeah. To take care of that infection, that it does not cause more thrombosis. And differential diagnosis can be orbital cellulitis because there was periorbital edema, bilateral periorbital edema, and cranial nerve palsies are rare in this orbital cellulitis. But because we had also cranial nerve palsy, double vision, so this is ruled out. Acute angle closure glaucoma and brain abscess. But in brain abscess, there are no eye symptoms. If it is localized abscess, but we have here, so these were the differential diagnosis, and this is the definitive diagnosis. The other one was Ludwig's angina. as all of you know from your previous medical lectures, that what is Ludwig's angina? Is a form of cellulitis or connective tissue disorder that affects the submandibular, sublingual, and submental spaces. That is the area under the tongue and the neck region. Yeah. So we have tongue, we have genoid, sublingual, mylohyoid muscle, submandibular space, and superficial facial space. So this area can cause cellulitis, and the connective tissue is involved. And when the connective tissue is involved under the area of the tongue and the neck, the cellulitis is there. This is known as Ludwig's angina. So cellulitis of submental, submandibular, and sublingual regions. They should be sublingual regions too. Virulent streptococcal organisms. So we have virulent species of streptococcal organism bacteria, right? What is cellulitis?
Sir, it is one stage before the stage of abscess, sir. It is a superficial infection that further concludes into an abscess, sir. It's known as cellulitis.
Perfect. It's a superficial. The term is superficial infection. One of the superficial infection, cellulitis. Can you name other infections of the skin? Or you forgot?
Sir, like cellulitis, thromboinflammitis is there.
Thromboembolitis. Okay, and then what else? Okay, superficial infection of the skin. One of them is cellulitis.
Fungal infection is dermatomycosis.
Oh, this is very general. I was talking about impetigo and
Sir, like trunculosis, carbuncle.
Okay, good. Yes. Trunculosis, yes, and then
impetigo.
Yes, exactly. Thank you. So cellulitis is one of the superficial infections. Yes, cellulitis is one of the superficial infection, is non-suppurative inflammation. So cellulitis is superficial, non-suppurative, no pus inflammation. So inflammation, because it is inflammation, is non-suppurative, no pus, and is superficial, spreading along the subcutaneous tissue. Because under the skin, subcutaneous. How cutaneous is what? Cutaneous, cuta is skin, and subcutaneous means under the skin. Under the skin, the tissue is known as subcutaneous tissue, and cellulitis is spreading and is restricted to the subcutaneous tissue and connective tissue planes across the intercellular spaces. So cellulitis is superficial, non-suppurative inflammation in the subcutaneous tissue, spreading along the subcutaneous tissue. And we have risk factor for this 6C, and amazingly, surprisingly, the first one is caries tooth caries, dental caries. The first risk factor, or the most common risk factor for Ludwig's angina, is tooth caries. And then there can be cancer of oral cavity, calculi in submandibular gland. Yes, submandibular gland can have calculus, chemotherapy, cachexia, chronic disease, diabetes, like such as diabetes. What is cachexia? Anyone?
Sir, muscle weakness.
Cachexia is, yes, thinning, or yes, you have less muscle mass. Okay, kind of that. Good.
It is wasting of muscle, sir. It's wasting of muscle, sir.
Loss of muscle mass, most commonly seen in
Loss of muscle mass. Okay, good. Good. Okay. So now we go for the clinical features. This was a good example or good picture, because for risk factors we have 6C, and clinical features were HOPE. HOPE means high grade H for high grade fever with toxicity. Edema of the floor of the mouth is a characteristic for this, or hallmark for this Ludwig's angina. There is edema of the floor of the mouth, frog-like edema. Frog, there's a floor of the mouth under the neck and lower jaw. He has edema. Naturally looks like that, and it is a characteristic for the Ludwig's angina. Putrid halitosis, bad breath. Elderly patient with brawny edema, right? Easy. My name is Ludwig angina, but I don't cause angina. Okay. Management. How to take care of Ludwig's angina? For cavernous sinus thrombosis, we can give broad spectrum antibiotics and maybe some blood thinners or platelet inhibitors. And then hair management is rest and hospitalization, appropriate antibiotics because it's still an inflammation, IV fluids to correct dehydration, Royal's tube feeding, so there is no pain during feeding, and surgical intervention if needed to reduce the inflammation and to open the area. So I will be happy if some of you guys during the viva, if is conducted, answer these questions. Okay, next we go for the sign and symptoms of the dental caries. Okay, so what are the signs and symptoms for dental caries? Caries initially involve only enamel and produce no symptoms. Initially, enamel and dentin, no symptoms. A cavity that invades the dentin causes pain if deep dentin, because we know there are some dentinal tubules, and dentinal tubules go all the way to the dentin. So superficially, maybe not that severe, but mid and deep dentin, we have dentinal tubules, and because of the fluid, because the nerve endings from the pulp are submerged in the fluid, dentinal fluid of the dentinal tubules, which tubules are across parallel to all of the dentin. That is why when dentin is involved, the teeth become sensitive to hot, cold, sweet foods and beverages. Beverages are cold drinks. So a cavity that invades the dentin causes pain first when the hot, cold, sweet foods or beverages contact the involved tooth, and later with chewing or percussion done by the doctors. So while eating, they have pain. So if you say this picture that dental caries was not painful, is not totally truth, right? It's not totally true, because dentin have these dentinal tubules. Dentinal tubules have fluid, and fluid, what is submerged in the fluid? That is the nerve ending from the pulp. So this is not totally true. Dentin caries are somehow painful. Initially, how painful? Initially, by sensitivity, increased sensitivity, hot, cold, sweet food, beverages, and later when the pain and later by chewing and percussion. The pain can be intense and persistent when the pulp is severely involved. So pulpitis. So here we have warning signs of cavity: consistent toothache, increased tooth sensitivity and pain. It means dentin is involved, right? And it is going towards the pulp. And if pulp is involved, then we have pulpitis. We can have pulpitis, which is harmful, painful. We can have abscess, periodontal disease, periodontitis, which is also painful, health painful. So we don't want to take it that. So these are the warning signs: consistent toothache, increased tooth sensitivity and pain, noticeable holes and pits in the affected tooth, that we need to take care of the teeth. Either we give some amalgam or filling to take care and to save the teeth, because it's permanent, it's not going to come back. And then we will go for the diagnosis, right? And diagnosis include inspection of all visible tooth surface using a good light source, dental mirror, and explorer. So explorer is a bent dental mirror which can be used to diagnose the dental caries. Dental x-rays may show dental caries before it is visible. For example, if you cannot see the cavitation or detrimental teeth, then you can use x-ray to see if there is ongoing infection inside the teeth, ongoing caries, cavitation, formation of cavitation inside the teeth. You can use x-ray. In particular, caries between the teeth, and in particular caries between the teeth, you can also find interdental caries, pit fissure type. This is known as pit fissure type. Okay, large dental caries is often apparent to the naked eye. You can see, you can use a dental mirror and explorer to see large dental caries because they can be seen with the eye, but smaller lesions can't be difficult to identify. So large dental caries is often apparent to naked eye, but small lesions can be difficult to identify. No big information here. Visual and tactile inspection. Tactile includes percussion. Visual and percussion inspection, these are inspection along with radiographs, are employed frequently among dentists in particular to diagnose pit and fissure caries. So we have caries diagnosis we can do by inspection, we can do by electrodontometry, we can do by vital staining, we can do by probing of tissues, use a probe, percussion, luminescent method, thermo test, include the sensibility to hot and cold, and row and genography we can perform. Okay, diagnosis table 1. This was, I was talking about occlusal initial lesion type 1. This is the occlusal surface, grinding surface of one of the molar, because it has multiple projections. That's why I can say it's molar. And this was the type first. In the previous slide, I told you that next slide we have type 1 occlusal lesion. And this is the, it looks like this, superficial. Okay, so dental caries diagnosis table 1. Table 1, this is caries diagnosis and management system continuum as proposed by the International Caries Detection and Assessment System Committee. Primary prevention at the patient level. We see no disease. We see initial lesion type 1, initial lesion type 2, moderate lesion type 3, and then moderate lesion type 4, extensive lesion type 5, extensive lesion 6. So this is the staging of lesion severity. If you ask me, ICDAS is what? It is International Caries Detection and Assessment System. It's not a big deal, but if you just remember type 1, type 2, type 3, type 4, type 5, and type, or stage 1, stage 2, stage 3, stage 4, stage 5, it's good. So initial 0 and 1 stage is, or maybe 0 stage is this, and there is no lesion, and 1 or 2 stage is initial lesion, and then 3 or 4 is moderate, and 5 and 6 extensive stage lesions. Okay, so this was International Caries Detection Assessment System, staging of lesion severity. And then you can say there is no cavity here up to here, and then caries lesion activity assessment this, and then we should perform radiograph to see. So here we can, for these type stage 1 to stage 6, we can go for caries lesion activity assessment, that is by naked eye, percussion, and whatever we have seen previously on the diagnosis, which were these steps, dental x-ray and this and these, right? We can perform. And radiographs should be performed from stage 0 to stage 6 to see if they are healthy or not. Okay, how much time remaining? 4 minutes. Okay, and then we have caries disc assessment and the tooth surface level and diagnosis. So if this stage, no treatment. If this stage, remineralization. If this stage, arrest, salient use, minimal surgery, traditional surgery, endodontic treatment. Endodontic treatment is root canal treatment. One of the, this is root canal treatment, and then extraction. If there is too bad, then we have to do extraction. If there is no lesion, no treatment, and according to the lesion, we can do some treatment. Arrest, how to arrest? Give antibiotics to arrest the infection. How to give saline? You can arrest and amalgam, give some filling to the teeth. Okay, perfect. And then there is no treatment, there is secondary prevention, and then there is tertiary prevention care. So this is very good overall of diagnosis of dental caries. Now we go to random assessment of our own class, dental caries. Hamid, roll number 0 to 8.
Yes, sir.
Okay, so can you tell me something about enamel caries? Enamel caries?
Sorry, sir.
You cannot tell me anything about enamel caries, Hamid? Can you see the slide? Can you see the screen?
Not clear, sir.
So you are not clear.
Network
so can
problem.
you see the screen in here? Can you see the screen?
Yes, sir. I see, but screen is not clear, sir. Network problem.
Network problem. Okay. So enamel caries.
Yes.
Can you tell me what is enamel? Is it the outermost layer or the innermost layer? What is enamel? Can you just tell me anything? Okay, Amit, we'll talk later. So roll number Miraj Abid, roll number 38. Are you here? Can you tell me something about enamel caries? Can you tell me something about enamel caries?
Sir, it is the initial lesion of the white spot due to the deimmunization of subsurface layer its attack changes from the smooth to the layer by becoming stained. And it is if lesion is progress, then it's pitting and eventually cavitation occur.
Perfect. So you just use the red demarcation and you explain everything about it. So this is what I want you to remember. Perfect. Good job. Okay, so now we have, do we have roll number 16 back? Roll number 16 back?
Yes, sir. Assalamu alaikum, sir.
No. Well, exam. Perfect. Okay. So can you tell me something about dentine caries? Dentine caries here.
Sir, I'm sorry, my server was not working, sir. I was unable to join the class.
Can you see the slide now?
Yes, sir,
Can
definitely.
you tell me about dentine caries? It's here. Can you tell me something about?
Dentic caries. Dentic caries comprises demineralization followed by bacterial invasion.
So
So,
dentine is
sir,
first. Okay. Okay, I hope you know next outermost is enamel and the next to enamel is dentine. I hope you know. Okay, so see you after the class. The session is almost over. See you after the break actually.